Yes.
We are excited to host yet another webinar. Thank you to all who have joined on time. My name is Dr. Elizabeth Wala. I'm the Vice Chair of Kenya Healthcare Federation, and will be your host for today. We have our guest speaker, Dr. Jeremy Gitau, who's the head of department for the emergency unit at Kenyatta University Teaching, Referral and Research Hospital. And he's also the chair of the hospital's COVID Champions Response Team. With me are my colleagues from Kenya Healthcare Federation. That's Dr. Amit Thaka. Please say hi to the audience.
Hello, everyone, and thank you for joining us. Thank you, Dr. Wala, for putting this webinar together. Thank you.
Okay, and we also have Dr. Anastasia Nyalita, the CEO of Kenya Healthcare Federation.
Good morning, everybody, and thank you, Dr. Wala, for putting this together, and to Daktari for coming on board.
And we have Leah, who is our admin and who's responsible for making sure we are all connected. Leah, do you mind saying hi? Okay, we'll give her a bit of time later. So without further ado, our topic for today is about care in isolation facilities for patients who have COVID-19. And today we have a special interest or a special presentation by Kenyatta University Teaching, Referral and Research Hospital. And we're going to see what they're doing. So I'll be very brief in terms of the ground rules. This webinar is being recorded. You have been muted so that we allow maximum participation by all. But then you have two options in terms of feedback or questions. On your right-hand side, or maybe it's on your left, there's a Q&A box, the one that I'm circling. This allows direct responses if you chat a question or a comment, but then you also have the option of a chat box. The chat box is visible to others, and it's not possible to respond to individual chats. But I have my team, Dr. Amit and Anastasia, who are in the background, who are collecting all this information. We'll have a question and answer session at the end where we'll summarize what's coming out from the chat box. So this is a safe space. It's not meant to replace professional help. For that, we kindly ask you to call 719 or SMS 719, which is the National Response Team. That's the agenda for today. I'll give you introduction and an overview of COVID-19, and then we head straight to a presentation from Dr. Jeremy Gitau, and finally a question and answer session. We don't expect to go over 1 hour, so we ask for your indulgence of this time. Now, in terms of the background for Kenya Healthcare Federation, we are the health sector board of the Kenya Private Sector Alliance. We have a COVID-19 response team as private sector. Where I'm pointing on my right is the Office of the President, which is responsible for the overall national response. There's a committee that was gazetted that's led by CS Matiang'i, and it has various sectors there. Health is what is of importance for us, but then we also feed into the others because we are citizens of the country, as well as the aspects of business and economy, food and security that still touch on our sector as health. But if you look below that, there's a KEPSA Business Action Platform that is our mother, so to speak, organization. And as healthcare, we have Dr. Amit Thaka, our chair, who is our representative on that business platform. But specifically going to the Kenya Healthcare Federation response team, we have various committees, and I'll show that to you in the next slide. And we feed directly to the Ministry of Health. We have weekly meetings with them to exchange information and also to share our experiences. And then we have Kenya Healthcare Federation board members, some of whom sit on the COVID-19 task force at the Ministry of Health. So that is a general outline of our organizational structure for the response team. Now, going into a bit more detail, this is the pictures of the people of the team that's leading the response team from the KHF side. So Dr. Meet is there as a chair, I'm there as a vice chair, then we have the CEO, and then we have 6 supply chain committees handling various institutions, for example, supply chain, we have healthcare financing, we have ICT and mobile health, partnerships, communications and resources, health regulations, quality and standards, and human resources for health. This is a very busy slide, but it's building up to our discussion for today. We have special intervention groups. For example, we have a committee where we are liaising purely with the top leading hospital CEOs. We have another one on legal and advisory with the lawyers. We have one with the Architectural Association of Kenya members and people in the built environment looking at infrastructure. We have a fourth one on critical care. This is looking at our ICU capacities. And then we have a special one just looking at telehealth. And last but not least, we have one that's purely on medical gases. So all these intervention groups build up as and when need arises as we go along in this response. This is just a brief slide looking at the kind of facilities and who are in our CEO's working group. So you can see we have a variety of private hospitals, we have faith-based organizations, and we have public hospitals. So last time we picked Aga Khan University Hospital in our session, our webinar, which will be has been uploaded on our KHF YouTube channel, so feel free to go to that. Today we are speaking to a public facility, and that's Kenyatta University Teaching Research and Referral Hospital. So that is about the introduction bit. I'll just go also briefly to what are we seeing in terms of our data. This is data as of 26th of April, 2 days ago. When we plot Kenya's map in terms of cases, actual number of cases from the first day of testing a positive patient, you can see Kenya's map is gradually rising, not as steep as the ones in the West, but if you compare it to the East African region, Kenya is leading in the number of cases, but again, this data needs to be interpreted in light of the testing capabilities. So the more you test, the more likely you're going to get positive cases. Now, how do we look at when we talk about what happens with a patient who's had a positive case or suspected to have COVID-19? Very briefly, we look at 4 different areas. So the ability of how a facility will interact with a patient or a possible case of COVID-19. We have the screening and diagnosis center. It's important that facilities have this separate from the other types of patients that they see. We have those patients who will get admitted. Again, there's need for segregation for that. We have discharge and rehabilitation process should also be separated. And then we have other cross-cutting factors, which means that even as the services are being provided, we need to consider isolation of patients who have an infection like COVID-19. But we'll hear more from Dr. Jeremy as he talks about. There's some few examples that were picked out, and this is a very busy slide, but looking at China being the first country to, of course, report a COVID-19 positive patient, they quickly set up a network of specialist fever clinics. So these are just clinics that concentrate on testing people who have a high fever and symptoms likely to be of COVID-19 suspect. And then from there, the clinics are now able to feed this into a proper hospital. We also have another hub and spoke model, the examples from China and Italy, where we have hospitals that are dedicated for only COVID-19 because of the isolation, the necessary staff and infrastructure required. In Italy, what they did is to have a network of hubs to deliver COVID-19 treatment. So they had various smaller facilities that would really do more of the initial management in terms of testing and triaging. And then anyone who's positive is now fed into, or rather is now referred into a proper facility where they can access inpatient care. So that, in brief, is what I wanted to give you an overview. Our audience is consisting of both medical and non-medical, medical and non-medical people. I apologize, this slide should read Dr. Jeremy Gitau. So Dr. Masasabi sent an apology because he is taken up by official functions, but he is present with us and has given us our blessing and thus sent his representative. So we want to just screen a video that was shot by Citizen TV about Kenyatta University Teaching, Research and Referral Hospital on their experience, and then I will allow Dr. Jeremy to take us through the slides. So allow me to just screen this.
Do you need some assistance, Wala? Anastasia, can you hear?
I can hear you. Maybe we can proceed with the doctor as well. Tries
yeah,
to
if Dr. Wala stops sharing the screen, I can project the video if she needs that assistance. Can you give her a call?
Okay.
Hello?
Yeah.
Hello, Anna?
Yeah, Wala, can you hear me?
Yes.
Would you like that projection to be made separately? Then if you stop sharing your screen, I can project that video.
Okay, isn't it being seen?
No, it's not.
Oh my goodness. Okay. So just open the slide.
You might need to stop sharing so I can project my screen.
Yes, please. Okay. Apologies for that. I did assume that it was showing.
I want you to confirm that this is the video you were trying to share.
Yes, that's the video. Please go ahead.
Weird place on the landscape now. Positive COVID-19 cases, a highly contagious virus, are being managed here. And for the health workers, it's a fight they must win at all costs. Kenyatta University Hospital is Kenya's main treatment center. It's outside Kenya's capital of Nairobi along the Eastern Bypass. It's a new modern hospital, and so it offers the country lots of space in the battle against the global pandemic. Kenya has never experienced such an infection for decades, but there is always a first time. Numbers of those infected by the world's deadliest killer is rising by the day. Numbers of those hospitalized, an indicator of how Kenya is in the midst of an outbreak. We are in one of the facility's intensive care units, and a patient is really breathing hard, literally. There is neither a cure nor vaccination. His survival is hinged on hospital workers helping him breathe until his body can fight back the new coronavirus. It spreads through droplets when a person coughs, sneezes, or speaks. It only takes one to infect millions. It's deadly if the country cannot get ahead of it.
We have put both confirmed patients and suspected patients. They are here, but we have separated them. The confirmed are on one side and suspected are on the other side. Yes, but before we go in, first of all, we have to change.
It means you have to be in full gear.
Yes, you have to be in full gear for the PPEs. That is personal protective equipment.
This is literally Kenya's red zone and can only show the entire country what to expect if the virus continues to spread. This hospital is the most modern, up-to-date facility to be seen in East and Central Africa in recent times, and it has provided the government with space for the isolation and treatment of COVID-19 patients. But experts are warning that if the curve is not checked, then this facility could get overwhelmed. This is our journey into the contagion that is slowly but surely digging into the Kenyan population. It's tough to work or be in here. One must be brave. Any slight mistake could leave one infected. So staying safe starts with donning the process of wearing protective gears, masks, face shields, goggles, and gowns. Utmost care must be taken.
I feel scared a little bit. Yeah. But I have to do this. People have to know. Yeah. That's frontline workers as well. True.
Everyone in the ward, save for the hospital workers, is COVID-19 positive.
Knowing that I'm protected, I'm not afraid, and I can easily go in. And for me, I take them just as any other patient. I have to maintain their dignity because these are human beings. So I have to maintain that at all the times. So I attend to them just as I would attend to any other patient.
We meet with John Shearer, not his real name. He tested positive on the 2nd of this month and has been here since. John was traveling to South Africa from his home in Nigeria on the 23rd of March when he was quarantined at the JKA. He suspects that he acquired the zoonotic virus at the airport.
So I stayed at the airport from 23rd, 24th, 25, and 6th. And the condition there was not very conducive, and all that we were exposed to so many things. And the challenges, there was this elderly woman, I think she tested me positive also. She was also going to South Africa, and she from the same state. So try so many things I could to assist her while we were at the airport. So I just felt the exposure, the things I was exposed for those things from that 23rd to 26th before we moved to the quarantine center.
Dr. Jeremy assured him he will be tested soon to ascertain whether his body had managed to ward off the virus. But until then, his laptop and the outside environment he only enjoys through his window are what gives him hope.
It's not an easy challenge if your mind is not strong. It's difficult to take, but
so this is just to make sure we are reducing the risk of infection. What Yeah, all these doors have patients, and this is just one ward. You can imagine we have about 8 wards, so each door has a patient. There are some who have mild symptoms, others who are moderate, and then for the critically ill, that's the severe patients, they're in a different place. So that has helped us because we realized it's very easy for even an animosity to develop among the patients who are symptomatic, being put together with those who are symptomatic. So our plan is if we're able to divide them that way, then even in the wards, we're able, if in case our numbers outgrow, and you're not able to give every patient their own room, then you can put patients in one ward who are symptomatic, depending on their classification. The other thing that we are making sure is that even when in case we are going to do that, we are still maintaining the 1.5 meters distance. So the social distancing is also continuing even here. And every patient must have a mask as well.
As we left the tunnel ward, another challenge awaited: the removal of the protective gear. Anyone living here must always suspect that the gears have been contaminated and so have to be removed with care, the process they call doffing. Dr. Jeremy was the first to go. We followed, and our cameras were not spared. That is what isolation staff must always do.
We are also getting guidance from the Ministry of Health how to isolate people. If you come at the main entrance, you see that there is green and red. The red is for maybe people who are attending to the patients, and therefore they don't mix with everybody else. The red zone, we have the red zone, and now for us we have also the other zone, the green zone, if you call it that way. But so we are trying to do whatever we can to separate, so that if, for example, a lift is for the red zone, then it's just for the red zone. Maybe a lift is for the others. So we are trying to even here separate to increase the chances of keeping safe.
Initially, we were a quarantine center where we initially started eight clients, but since being categorized, we have now managed to see over 123 patients. Majority of whom now currently are positive and undergoing treatment. Most of them are stable, apart from one who is in ICU. Initially, he was in bad state, but he's really improving because he had some other comorbidity.
Government is urging Kenyans to strictly adhere to restrictions put in place, or the consequences could be dire. Kenyatta University Hospital says it's prepared to offer more space if need be. Enoch Sikolia, Citizen TV.
Many thanks, Dr. Amit, for coming in to just project the video. So I hope it was clear to everyone.
We are doing things a little different here on Weekend at One. So yesterday...
Hello, Dr. Amit, you might need to... Yes, so I want to take us back to Dr. Jeremy Gitau. So Dr. Jeremy, over to you. What we have seen, I think for many of us, it is this real? What exactly, when did KU get to these standards? How did you do it? What does it take? So take us through that, and then I'll ask you a couple more questions. Thank you.
Thank you, Dr. Wala, for the opportunity. Greetings from our CEO. Unfortunately, he couldn't make it for the meeting because of other engagements that he had prior. Yeah, but it's been an exciting and challenging time for us. Before, this is new for everyone, so we keep learning as we move along. Initially, as you are aware, we were in the process of opening the hospital. We had started initially with only 4 departments. That was the accident and emergency, oncology, renal. We had our ICU open, and we also admitting general medical and surgical patients. So we were actually in the process of opening the hospital fully to maternal and child health when COVID actually happened. And now we had to change everything to this. to cater for the COVID patients. So it's been a challenge for all of us, but we're learning as we move along. Yes.
Great, thank you, Dr. Gitau. Do you mind sharing with us if I happen to suspect that I have symptoms of COVID-19 and I have called 719 and they have directed me to KU Teaching Research and Referral Hospital? What should I expect?
So usually what happens is the Public Health Emergency Operations Center will send in, once you call and you have the symptoms, they'll send in an ambulance to pick you at your home. Or if you've tested and you're confirmed positive, they'll still send the ambulance. This ambulance will pick you, then they'll bring you to our facility. If you are admitted in as a suspected case, then we arrange for you to get tested immediately, depending on the time of arrival. Usually for people who arrive after 5 p.m., usually we'll test them the following day. For the other patients who arrive earlier in the day, we're able to test them actually on the same day. Results, the test is taken to the National Influenza Lab at Cambridge. We get results usually within up to 24 hours. So we'll get the results usually the following day for these patients. So the patient is with us, the suspected case is with us for between 24 to 48 hours until when we have a negative result. If the test is negative, then we allow you home on condition that you're able to self-quarantine for the 14 days. If you're not able to self-quarantine, then we proceed and keep you with us for the 14 days when we test you. And if you're negative, then we allow you home. For the patients who are admitted as confirmed cases, from the day of testing, we keep you in the hospital for 14 days, after which we do the retesting. That's if you're asymptomatic. If you have to get 2 negative tests between 24 to 48 hours apart for you to be allowed home. What we are seeing is majority of the patients are getting this, and after the 2 negative tests, they are being allowed home. However, there are a few patients who are continuing to be positive even after the 14 days. And if a test turns out positive after 14 days, we give them 7 to 10 days. At least during that time, we expect that their viral load will have gone down and they're not shedding the virus anymore. Then we retest. If it's negative, we do a repeat, and we still have to get the 2 negatives before you're allowed home. So even for the confirmed case, the same thing. If they're able to self-quarantine at home, they're allowed home for 14 days. In case they develop any symptoms along the way, then they need to be retested and checked whether they're getting either infection or the disease is coming up again. Yes. In addition, there are patients who are admitted as critically ill. These ones, we take them to the ICU. And for them, until when they are asymptomatic, and we've seen a couple of patients actually going through ICU and coming out. We have about 3 of them. And we wait until they are symptomatic before we can actually retest them. And then still get the 2 tests negative to allow them to go home. Yes.
Thank you very much. When I'm in the hospital, am I going to be all alone? Can someone visit me? What do I expect? Should I expect?
For isolation, there are no visitors allowed. And purely this is also to protect your relatives or your friends that want to visit you. So there are no visitors. We don't allow visitors. We don't allow any foods or anything from outside. And this is purely to protect the patient and also to protect you as a relative. So you're not allowed to come to visit. In the wards, as you've seen in the video, patients are put in the private room. However, the numbers have increased and we're not able to put all patients in the private rooms. So we have a criteria we use to allocate the patients in the private rooms. We've seen some mothers who have small children, the elderly, basically those who are vulnerable to severe disease. We've tried to give them their private rooms. However, the other patients are put in a ward, though we still maintain the recommended social distance. So you'll find probably in one room, the maximum number of patients you put is 5 to 6 patients with the social distancing allowed. Yeah.
Okay, you are working in that space as a
Yes.
healthcare worker, heading the department and the response team. Have you faced any fears yourself as a health worker? I would imagine if I was stationed in your facility that one of the things that would really scare me is every day this is what I'm facing. Do you mind sharing what you're going through?
I think despite all the arrangements we had, because when the first case was reported, we started planning. We had even started before that when we were seeing what is going on all over the world. But I can tell you for sure, when the call came in that we are receiving our first patients, I happened to be on duty that day, and it was not easy. You can imagine, especially for those with a family, you imagine you can get infected and take this to your family. So it wasn't easy. But what we've seen as we go along, we've managed these patients now for over a month. And I can tell you even the teams on the ground are starting to become more courageous. The other good thing is we've done testing for the healthcare workers, and fortunately all of them have turned negative. So meaning none of our healthcare workers has been infected. And this is mainly because of the support we've received in terms of personal protective equipment from the government. So there's no transmission of the virus to the healthcare workers. So this has given us confidence as we move along. Yes.
Okay. How are you relating to other facilities around you? Are you feeling like you're taking on board everything because you're a referral facility? How have the other services that you used to offer been affected by this?
So our biggest challenge was the oncology and renal patients. When we started this, we had a dilemma of continuing both streams, and we couldn't find a place where to transfer these patients actually. So we had to continue offering the services for the oncology and the renal patients. So this has been quite a big challenge for us. However, we've tried to, as much as you can see even in the video, is to separate what you're calling the green zones or the clean areas and the red zones, such that the patients don't interact with the staff that are, or other patients who might be going to the COVID area. So we've continued to offer the services. Also, our accident and emergency department is still open. We are receiving accident patients or any patients with any emergencies. So we've continued with this, as well as our ICU. I think that has been one of our biggest challenge, especially for the critically ill patients, especially those who come in as suspected cases. At times, you're not sure where to put them. Will you put them with the COVID positive, or will you put them in the different ICU where you risk other patients in the ICU being contracting the disease? So that has been one of the challenges with our critically ill patients. But other facilities have also come in. We've had a few of the patients admitted here also transferred to other institutions that have been approved to receive the COVID-19 patients.
Okay, and one last question from me. What do you think your hospital is going to get out of this experience of managing COVID-19? Are you going to come out with super stretched resources? Are you going to learn from the crisis? What exactly, where do you see the hospital gaining or losing from this response?
For me, I can say there's a lot of gaining, because maybe to talk of, for example, our ICU, being a public hospital and we were able to offer the continuous renal replacement therapy. I think that was new for a public hospital. So, and then looking at it generally, the issue of disaster response. So as a facility, we've been stretched, and what we've been using is what is called the hospital incident command system, which is applied during disasters. So I think if we were to get another disaster in the country, our hospital will be well equipped, and also the staff are well trained, and now they are aware of their different roles, because we had to come up, as you saw, we have this team called the COVID champions response team, and what it is actually a hospital incident command system team that has responded to this disaster, and we keep learning every day. So I think we're moving forward. In case of any disasters, we will be quite well prepared. The other advantage we had is our hospital we were in the process of opening it up. So we had the space, we had the beds, we had the building, and also what we've done is we've had to renovate what was initially our infectious disease unit. So in future, even for patients with other infectious diseases such as tuberculosis, we're able to follow them up in those facilities. So for us, it's a great opportunity to learn and to grow. Yes.
Okay. I think I would like to allow my fellow moderators, Dr. Meet and Dr. Anastasia, who have been looking at your chats and your questions in the background. Hello, Dr. Meet. Anna, do you have any questions from the chat?
Yes, Anastasia, you should go first and try and field some of the questions you might have picked up from there. Anastasia, over to you.
Okay, thank you, Amit. The one question that is coming up for Wala is CPD points. I think you can address that. And then for Daktari, by the 2 tests, does it mean spaced within 14 days? Maybe you can answer those ones. But finally, we have seen some counties setting up isolation centers at their level 5 hospitals, like in Meru. So this is Edmund from Meru. The isolation is at the Meru level 5 hospital, just next to the entrance gate. How safe is that for other patients? And then maybe Dr. Wala also, is there a commission or body to oversee and approve the quality of the isolation centers? Maybe we can take those ones for
now. I can start with the one for testing. For testing, for the confirmed cases, we test after 14 days if they have remained asymptomatic, and we have to get 2 negative tests. That's usually the test results takes about 24 to 48 hours to come back. So immediately you have a first negative, you repeat another one immediately, and if both are negative, then you discharge the patient home based on their ability to quarantine or not. Yes.
Mm-hmm.
Okay, sorry, I dropped off a bit. I will take the question on CPD points. So we have liaised with 3, hello, you can hear me? We have liaised with 3 professional associations. So we have Kenya Medical Association, Pharmaceutical Society of Kenya, and RISOC, who are offering CPD points. So at the end of this, we have your data through your emails. We will share with you the process of accessing these CPD points. Thank you. Then in line with the accreditation of facilities, this is done through the regulatory authority. In Kenya, we have the Joint Commission that is led by the Kenya Health Professional Oversight Authority, and they're the ones who are commissioned to accrediting facilities for registration and licensing in terms of offering services. And then when it comes to the specific COVID-19 response, This is wider stakeholder involvement. We have teams. I had shown earlier representation by the Ministry of Health COVID-19 response team, and they do have a particular committee that is looking into facility capability or capacity to offer isolation services. They are looking at mapping all the facilities that should be on standby lest we get to the surge phase, but they are also building the capacity of the same. Within Kenya Healthcare Federation, we have also mapped out our members, and we've shared this data with the Ministry of Health. Thank you.
Thank you, Wala. Maybe I can go the next two and then I'll hand over to Amit. So there's a question to Daktari. Do you still maintain normal hours? This is regarding the staffing. And do you work in teams? And if you do the teams get isolation breaks? That's number one. And the second one is about your assessment of our capacity to support hospitalized patients who require supplemental oxygen, because we expect, of course, as the surge goes up, the oxygen demand will go up.
Thank you for the questions. Yes. On the issue of staffing, so we do work in teams, each team having different cadres, but specifically for the doctors, each team has about, there are 4 doctors in each team. So they'll work for a period of 1 week. After this 1 week, they take a 1 week break. And during between the 10 and 14, we do the retesting. If the test is negative, then they join the cycle. In case any one of them has symptoms, then we immediately test them to make sure they've not been infected. So that's the way we work that's the issue of the staffing. When it comes to supplemental oxygen, the whole hospital there, we have a capacity of, we're able to take care of 456 patients. COVID, those are the beds we've set aside. And all these patients, we're able to offer oxygen actually to all of them. When the hospital was being built, the inpatient wards all have capability of providing oxygen. The new infectious disease unit has a bed capacity of 60, and we've also managed to pipe it with oxygen. So all our patients can receive oxygen if they need to receive. Yes.
Okay. Maybe 2 more. What are the challenges faced in refugee camps in COVID response? And also for Dr. Gitau, kindly confirm there are asymptomatic patients who test positive and are allowed to self-isolate at home, or are all who test positive admitted? They return if symptoms develop, or retesting after 14 days. So what do you do with the patients who are asymptomatic and they're positive?
Can respond to that. For the so what is happening? All patients currently in the hospital, in the country that turn positive, are all being admitted. And this is mainly, I think you've seen in the past, people are being asked to self-isolate and they couldn't do this at home. So what the government felt is all patients get admitted, and once they are recovered and they've turned negative, then we can allow them to self-quarantine at home. So currently, whether a person is symptomatic or not, they have to be admitted for the 14 days. Yes, thank you.
And the refugee, the challenges of COVID response in refugee camps, I don't know that you can take that one also.
I don't have much experience in the refugee camps. Maybe someone else can respond. I'm not sure about what is currently happening in the camps.
Okay, so one more for you is, do we have patients that come back with reinfection, and after discharge, are patients given TCA clinics?
So currently we are still early in the disease. In fact, I think we discharged our first patients about a week ago. Of those we've discharged, none of them has developed new symptoms or had any complaints that could suggest they've been reinfected. However, we have a team. What we've done is we have several teams in the hospital. There's a surveillance team that is following them up. So in case they have any symptoms, they immediately inform us. But none of them has had any issues so far. So we'll keep monitoring them until we feel they are fine. For these particular patients, we are currently not giving them a date to return to hospital. The only ones we've done this are the ones who have other comorbidities. Then they need a normal follow-up. For example, if a patient is hypertensive or diabetic, then they need to continue their follow-up in the usual clinics. Otherwise, most of them who've recovered, we just allow them home and only to contact us if they have any new issues.
Right, that's it from my end. Maybe Amit, do you have any additional questions?
I may not go into the questions, but I would like to maybe make comments with a few observations. So let me talk about the three main areas. So first, Dr. Jeremy Gitau, thank you so much for your time. And on behalf of the entire private sector and the health industry, I want to thank you for the incredible job you're doing. Not many people who are on this call or those who are out there can do the kind of work you're doing. So we are proud of you as a health worker. We are proud of you as a Kenyan, and we want to give you all the encouragement that you need and stay safe. That's the first point. You and your entire team at KU. On the same point, I can see that KU is almost like a flagship COVID center for us in Kenya. And the message after watching the video and listening to Jeremy is that we as Kenyans and the entire sector and the professionals who are in this call need to support what KU is doing together with its staff and team. On that same point, Jeremy, I have an ask for you. And the ask is that I'd like us to create training videos. The training videos will help other hospitals get more empowered and see what donning and doffing means, what isolation structures that you put in place. So when they see these training videos that you develop, many people in other counties across Kenya would feel more confident when they're dealing with patients, especially having seen what our flagship COVID center in Kenya is doing. There are two types of training videos. One will be on referrals, and the other will be on treatment of designated facilities. Not all facilities will be up to the mark of managing isolation and treatment in the COVID patients. So they would need to organize referrals. When they assure their relatives and their close family members on what to expect at Kenyatta University or institutions like those, you will allay fears from the family members. You will also allay fears within the patient. And this will reduce the curve that we are talking about in terms of transmission. And half the battle, if not more, is won in communication with this disease. So we reduce the stigma and the scare and the fear, which is why sometimes you see people jumping out of the third and the fourth floor and trying to say, if I go to a place, I'm going to die. And that's not the case. You have to literally be giving everyone a sense of confidence, and you can do that through these videos that you've already shown us one. And then finally, my last point, Jeremy, for you to respond on those asks is we may need to consider a phased model in Kenya. We are fortunate that we see very few deaths. One death is too many. We see very few infections. But as the surge rises, the phased approach in dividing the asymptomatic care and those that are symptomatic would need to be structurally managed, especially with field hospitals or open areas that don't literally need to come within the hospital for treatment across the centers. Finally, I also want you to comment on the oxygen concentrators and the hoods that we might need to use. Not everyone needs to go to a ventilator. Have you also experienced, they talk about the 80-15-5 model, where 15% just need some kind of oxygen through a unit, and it may help them, and they don't need to be ventilated. 5% ventilated, 80% will recover. So those are just my general comments. I'm not fielding the questions. I hope, Jeremy, you can respond to a few of those. Over to you. Thank you.
Thank you, Dr. Taka, for even appreciating our efforts. We are grateful for that. On the issue of the training videos, as you can see, as we are training research and referral hospital, so training is one of our key pillars. So currently what we are doing, and we have the suggestions of even doing the videos, we've been working actually with other facilities and giving them even talks about what the experience we've had so far. But I agree the idea of the videos will be welcome, and we also, I'm sure, will be coming to you for the support on this, especially on showing off what we've been able to do. On the issue of phased model, I agree with you, because what we've seen, and this is actually bringing a challenge to us, is, as you said, more than 80% of the people we are actually having admitted in our facility are asymptomatic. And so mostly they will be in the hospital, yes, they are receiving, because they have any minor ailments, they will be treated for them. But we feel as a research and referral hospital, a level 6 facility, if it was possible to have the phased model where these patients can actually be managed in a lower level facility, it would even reduce our workload and help us focus more on the patients who are moderate and even severely ill. And this would actually help in the long run, in case we get the huge numbers as has been seen in other countries. I think for us, the good thing is that we've seen counties and other facilities coming up and getting ready to manage these patients. So we are hoping going forward, not every patient that turns positive will be coming to our facility, so that we are left with the ones who are moderate and severely ill, that we can help in our facility, that is able to offer the oxygen and even the critical care. As we had mentioned, we at our facility, we only have 24-bed ICU, purely for COVID. So we agree, if our resources were to be geared to the moderately ill and critically ill, then this would help us also manage well the patients that we are seeing. Yes, about the oxygen concentrators, what we are doing is we have a model. Any patients that are requiring less than 4%, that actually requiring more than 4% of oxygen, those are patients who we are managing in the general wards and giving them oxygen by an breather mask or even nasal cannula. Anyone who is requiring more are the patients we are watching closely, preferably in the ICU, because what we've seen, these are the patients who end up requiring admissions to the critical care unit. So we are tending to admit them earlier than we would for other regular patients. Yeah. So thank you for your comments.
Excellent. No, it was, thank you for that. I think one of the concern is the bills. I don't know whether we clarified who pays at discharge on from your facility. Is there a structure in place?
I think from the day one, the minister has been very clear that patients who are admitted in the isolation facilities will have to pay for their bills. And this has been going on. This said, there's a committee that sits down under the finance director of the hospital that looks at the patients, and if anyone is not able to pay, then we're able to see ways where the bills can either be waived or alternatives. We've also seen some other bodies come in and pay off some of the bills for some of the patients. So billing is a big issue, and I can say we are addressing it, but we handle it on a case-by-case basis. Yes.
Yes, I think the ones who can't pay will have a real double whammy, so to speak. I hope NHIF is helping, and the resource center that we are trying to raise money, and the COVID fund, especially in the early phases. I think we need to allay fears of bills, and I wish that team all the best. And if they want to reach out to the private sector, let them know that they can, speak to us. But it's a concern across the country, not only in the public facilities, but also in the private. And now it's going to become an economic issue. And then how about your staffing, Jeremy, in terms of the skills required and the projections of the team members you need, especially in the intensivist unit? Are you okay and comfortable with that, or you are on the employment pathway right now?
As we speak, if the numbers keep going up, we will definitely be overwhelmed, especially in the critical care unit. Currently, as we speak, we have 4 specialists, 4 anesthesiologists who are taking care of the patients. And remember, this is a disease where you can't be exposed to throughout. So they do weekly shifts. So based on the ratios, we've actually given for every anesthesiologist a maximum of 8 patients to take care of. For the medical officers, we are doing a ratio of 1:4 patients. So in case we get more than that, if we get more than 8 patients, it will become a challenge in terms of the rotations. So we may require to recruit more. We are in the process. We've already given our proposals for new staff. So we believe soon we'll get more to come and assist, even if it's on short-term contracts.
2 more points I have, Jeremy, before I hand it over to Wala. One is, the patients who are recovering and they actually are able to ward off the virus, are there plans in place to use their plasma or harvest some kind of therapy on blood and blood products to assist and strengthen the fight of other patients who might be weak and cannot ward off the virus? What are your thoughts of that? Have you considered that approach?
It's something that we've considered. I think most of these are still experimental in most of the countries. Remember, COVID is still a very new disease. And so it still has to go through the ethics approval and all that. But it's something we've actually thought about, of how we could talk to the patients, get their consent, and allow them to give us their plasma for use in other patients. So all these are part of the things that we are looking into, and treatment modalities that we'd want to offer to the patients, and probably even write about them in the medical field. Yes.
Yeah, finally, before I hand it to Wala, South Africa brought in 1,000 Cuban doctors, and the discussion about a medical brigade, and I'm hoping that we are fit for purpose in Kenya. We can manage ourselves, but South Africa brought in a medical brigade, and other countries like Italy did that. Have you guys thought of that? And has that topic come up in your meetings? What's your view?
What we've discussed is more of, as you are aware, there are several unemployed doctors in the country even before COVID.
Correct.
So, yeah. So what we've discussed is having them on a short-term contract in case the numbers become overwhelming. And I think if we're able to stick to the doctors who we've currently trained, we may not get to the levels where we need support. But that said, in medicine, there's nothing which is absolute. So in case we get to that level, definitely we need support from outside. Yes.
Thank you so much, Jeremy. Over to you, Dr. Wala.
Thank you very much, Dr. Amit, for those probing questions. I also want to appreciate our audience for the chats and the questions that we've been receiving from your end. This session has been recorded, and we'll have the information on our YouTube channel, anonymously, of course. The whole recording will be there. You are also free to further interrogate the video that was shared by covered by Citizen TV on our own facility. It's a public facility. We are very, very proud of Dr. Jeremy, you and your team. Please pass our appreciation. Do you have any parting shots before we close the webinar for today?
I think for me, the message to the public is they need to follow what the ministry is saying. I think as we've seen, it's very possible to flatten the curve if people will stay at home and use the masks in masses. That is the only way we are going to fight this disease. I think for us, it's been a challenge, but we are coping. So watu wakae nyumbani and they wear the mask. Yes.
Thank you so much, Dr. Jeremy, you and your team, for sacrificing your lives and your skills to ensure that we are all safe. I think we've heard it from the frontline workers. They're doing their best. Let us adhere to the recommendations and regulations that have been set out for us. So thank you for being with us today. We have more webinars. Check out our Kenya Healthcare Federation platforms, that is social media, LinkedIn, Facebook, Twitter. We have at least 4 webinars per week, so plug in for our series. We will see you next week, same time. Thank you very much and have a nice afternoon.